Hi, my name is Monnica Williams, and I am here today to talk to you about sexual obsessions in OCD. A little bit about myself. I am an associate professor in the School of Psychology at the University of Ottawa, and I serve as the Canada Research Chair for Mental Health Disparities. I'm also the clinical director of the Behavioral Wellness Clinic in Tolland, Connecticut, where we specialize in treating OCD at our New England OCD Institute. I'm board certified in behavioral and cognitive psychology, and I'm a licensed clinical psychologist in the United States and Connecticut. So I wear a lot of hats and I do a lot of research, and I have done a great deal of research on OCD, particularly OCD symptoms and understanding sexual symptoms in OCD. So OCD is a serious illness. It involves distressing obsessions and repetitive compulsions that get in the way of daily life and functioning. Obsessions, you may know, are intrusive, unwanted thoughts, images, or impulses that increase anxiety, whereas compulsions are repetitive behaviors or mental acts that are used to decrease anxiety, although not always successful. OCD is a serious illness in that it is a leading cause of disability worldwide, and at one point it was even named as a top 10 cause of mental health disability. Although that ranking's gone down a little bit, it still gets to the point that OCD is severely debilitating. Over 112 million people worldwide suffer from OCD, based on an estimate of about 1.5% prevalence rate, or 1 in 50 people having severe or mild or subclinical symptoms of OCD. Now you may be wondering how OCD works. So here is a little overview of what happens when a person has OCD. They have obsessions, which are these unwanted thoughts that they cause distress. They lead to, or they could be urges or mental images, and these thoughts cause anxiety. And this anxiety can be distress, fear, worry, or disgust, but either way, it's a false alarm, and it's as if the brain is on fire saying, watch out, we need to do something. And that something in OCD is a compulsion, also called a ritual. This is any behavior performed to help make that anxiety go away. And so then, after the compulsion, the person feels a little bit of relief. But unfortunately, that relief is only temporary because the obsessions come back, and this time they come back even stronger. And so then the person remembers, oh, the last time I had an obsession and it caused anxiety, I did a compulsion and I felt a little better. So they do the compulsion again and again and again. And that's how people get stuck in this OCD cycle. Now, OCD can come out in a lot of different ways. And here are the most common, what we call symptom dimensions. Sometimes people call them subtypes of OCD. You probably have all heard of the contamination and cleaning dimension of OCD that includes worries about germs or feelings of disgust, and includes compulsions of washing and cleaning. You may have also heard about symmetry and arranging OCD, and this includes behaviors such as evening up, feelings of just right, touching, tapping, repeating. Also, in this lower corner here in the light yellow bubble, we have doubts and harm. And these are people who worry about causing harm accidentally. So they will be repeatedly checking for safety to make sure that they haven't left a stove on or a razor blade on the floor that somebody could step on and get harmed. And then finally, we have the unacceptable taboo thoughts. And that's where most of these sexual obsessions in OCD lie, in this category that includes a lot of ruminating, mental review, reassurance, and checking. Now, I'm not going to go into so much detail about the related disorders, OCD-related disorders, which include things like hoarding, obsessive concerns about appearance, which is called body dysmorphic disorder, health or illness anxiety, and these things are also often on board. And most people that I work with OCD have worries in more than one of these bubbles. Usually there's a primary one, though, that's causing the most trouble, although I have seen people who have major symptoms in 2 areas and sometimes even 3. And so when I work with clients, I ask, which kind of OCD do you have? Do you notice symptoms in more than one area? How have you coped with the symptoms? Many people experience a lot of shame around their symptoms, and that's not uncommon, especially for these unacceptable taboo thoughts, which are less well known. Now, if we take that category of unacceptable taboo thoughts and we blow it up, you find that there's actually some subclusters within these thoughts. And one of those subclusters, the main one we're going to talk about today, are the sexual ones. And these include worries about sexual orientation, being a pedophile, committing a sexual assault. There are other subclusters as well in this category, which includes, over here on the right, scrupulosity, which just means like a hypermorality, and people may have extreme religious concerns. They're worried about always doing the right thing. Another group is aggressive urges, and these can be the impulse to harm other people in other than sexual ways, like to punch someone or to stab someone when they're, or even theirself when they're not angry. And then finally, we have related concerns, which could be worries about health and illness, which seem to also cluster among these concerns as well in some research studies and my own observations. There are many barriers to treatment for people with OCD. And for one, people have a long time finding treatment. And part of this is because they just take a long time sometimes to even look for treatment. One study found that people with OCD suffer for 8 years on average before seeking treatment. And then it may be many more years before they actually find the right treatment. They often hide their symptoms due to shame, or they may not recognize their symptoms as fitting into what's thought of as typical descriptions of the disorder. And then finally, mental health and medical professionals may have difficulty distinguishing OCD from other disorders. And in fact, OCD is very, very much missed in general practice. So these are some reasons people don't get help. And you'll find that all of this is worse for people with sexual obsessions and OCD, that we sometimes call S-OCD, because all of this is heightened, and I will explain why. So for one, OCD is frequently misidentified, and what we found was that our psychologists did not do that well. Now, most of them got the symptoms about contamination obsessions right. They knew that was OCD. Only 15.8% misidentified that one. But as the symptoms got more and more away from contamination, people got less and less accurate. So 28.8% misidentified religious obsessions as part of the disorder. 77% misidentified sexual orientations as OCD and actually classified the problem as sexual identity confusion. And 43% misidentified sexual obsessions about children, with over a third thinking that that problem was pedophilia. So this is quite tragic, because in a mental health setting, this really could amount to innocent treatment-seeking patients being reported to Child Protective Services just for trying to get help, which I have to say I have sadly witnessed on more than one occasion. So if licensed psychologists can't identify common forms of OCD, there is little hope for lay people with sexual obsessions to ever get a proper diagnosis. It's not uncommon for me to hear horror stories from our clients because of misdiagnoses that they received at the hands of prior medical professionals who frankly should have known better. These clients were the lucky few who, despite being misdiagnosed, kept looking and eventually found the right kind of help instead of giving up or worse yet, many people with this kind of OCD sometimes feel so much despair that they end up attempting suicide. How many people have sexual symptoms in OCD? Well, it's hard to know because not everybody who has this ever speaks out, and because of the big problem of misdiagnosis, we don't know for sure. But what we can say is in one of the largest studies ever of clinical OCD symptoms, which was the DSM-4 field trial, this included patients receiving treatment from top OCD specialty clinics at 7 urban sites. And in that study, 17% of patients reported current or past sexual obsessions as a primary or secondary concern. That study was done quite some time ago, but in other more recent studies, we've seen a large number of people with these concerns as well. For example, 17% of patients reported current or past sexual obsessions at one clinic in Pennsylvania. And in a large nationwide study, 30% of those with OCD reported sexual or religious obsessions, but we don't know exactly how much was just sexual because they didn't separate them out in that study. But looking at studies in the US and abroad internationally, it seems that between 20 and as high as 50% of those with OCD have some sexual obsessions. Sexual obsessions can complicate treatment. Unwanted sexual thoughts have traditionally been considered difficult to treat because of their taboo and stigmatizing nature. Those suffering with these thoughts are often experience intense shame and guilt, and so they're less likely to talk to others about their OCD due to fear of social rejection. And so this could be one reason why it takes them longer to do well in treatment, and one reason why it takes them longer to find treatment if they find it. And their worries about being stigmatized are not completely unfounded because research has shown that these thoughts are less acceptable, even within OCD, than other types of themes in OCD, such as contamination or checking. So people do feel a lot of shame and stigma. And so this is why we think that the numbers could be higher than we may ever know in terms of how many people have this. Now, as I pointed out, most people with OCD have worries in more than one area, so sometimes they may only talk about worries in one area, not talk about the sexual symptoms, but you have to treat all of it, or this can result in treatment failure or relapse. It's important to understand the difference between an obsession and a fantasy, and sometimes people confuse these or mix these up, and I've seen even clinicians use the term fantasy to describe someone's obsession. These obsessions are not enjoyable, so this is the difference between an obsession and a fantasy. So normal sexual fantasies are enjoyable and generally harmless. They may include wishes or memories of past sexual experiences. However, sexual ideation in OCD, it is unpleasant and distressing because people don't want to have those thoughts and they don't want the thoughts to become real. The sexual obsessions in OCD rarely produce sexual arousal and in fact usually will decrease sex drive because we know anxiety gets in the way of having good sexual experiences. And these obsessions result in guilt, shame, distress, and anxiety. As I mentioned before, common sexual themes in OCD include pedophilia, unfaithfulness, incest, even bestiality, worries combining religion and sex, and same-sex sexual behaviors. Sexual obsessions seem to be equally prevalent in both male and female OCD patients, although some research I did, it looked like they were more common in males, but more distressing in females. But jury's still out on that. But either way, people with this it can strike males or females, and in either case, it needs to be addressed. Now, I showed you my little circle of the OCD cycle, And this is how, this helps break it down a little more for you in terms of the symptoms people are having. So at the top here you see obsessions. And the way people respond to their obsessions could be compulsions, as we talked about before, but they can also be avoidance. And both of these need to be addressed in therapy for people to get better. Otherwise, what happens is all the avoidance causes a person's world to get smaller and smaller, and all the compulsions continue to suck up time and energy. And there's two kinds of compulsions that we talk about: overt rituals and covert rituals. So overt rituals are things that everybody can see you doing, like washing your hands or going back 5 times to check to see if you left the flat iron on. Covert rituals are often very subtle and may not be recognized as compulsions, or they may completely happen in your head. We call these mental compulsions. Mental compulsions can be things like special words, images, numbers, recreated mentally to neutralize the anxiety caused by the obsession. They can be special prayers repeated in a set manner. It could be mental counting, mental list making, mental reviewing, mental reassurance. Someone could reassure themselves. Also, they may be what we sometimes call somatic checking, which is best described as somebody kind of mentally checking their body for signs of illness. For example, where someone with illness anxiety may constantly check themselves for signs of a fever, a person with sexual concerns and OCD may check for signs of sexual arousal, for example, when they're around people that they feel like they shouldn't be attracted to see if they're attracted, or when they're around people they think they should be attracted to confirm that they're actually attracted to the right target. And I put right in air quotes because this is all about what their OCD is telling them is right for them. So for example, if someone has sexual orientation concerns, they may check how they feel around people of the same sex to make sure that they don't feel any sexual arousal. And if they don't, then they feel assured that, okay, I'm not gay, so maybe I don't need to worry. Of course, we know with OCD, the worries just keep coming back. So you may have heard the term SO-OCD, which is what we often use to refer to sexual orientation OCD. It's also been called HOCD in online communities in particular, where it stands for homosexual obsessive compulsive disorder, but it can strike anyone of any sexual orientation. So we thought the term SO-OCD was a little more inclusive. And it could include fears of being unconsciously or becoming LGBTQ, or it could be the experience of intrusive, unwanted mental images of the same sexual behavior, or that others may believe that that one has a same-sex attraction when they don't. Usually it goes that way. I have seen it go the other way, where you have someone who is LGBTQ worried that they may actually be straight. And the compulsions for this, again, are things like reassurance, which could be self-reassurance, but it could be asking others for reassurance, mental compulsions, and again, this checking, particularly the somatic checking that I described. Here's an example from a client who has SO-OCD, and I thought her story was very compelling. She says, "I'm a 37-year-old woman who's had OCD about being gay since I was 11 years old. I've gotten CBT before, but the treatment only made me worse. I'm currently on medication too. I've only ever dated men, and I only want to be straight. I have been doing well with the OCD until last November, when I had a dream where I asked a dream figure, 'Am I a lesbian?' And he said, 'Yes, you've been in denial, but you've just been too scared to admit it.' The dream terrified me so much that I attempted suicide a month ago. I'm so scared that this is definitive proof that my subconscious is saying I'm gay and that it must be true. I realize that sexual content in dreams is symbolic. And it doesn't necessarily mean what it appears. However, my dream was not symbolic with sexual content, but it straight out said I was a lesbian and in denial. I'm terribly concerned that this might not be OCD." Okay, so you may have heard of something called POCD, and this is just shorthand for pedophilia-themed obsessions in OCD. And I want to be really clear with this one, that when someone has thoughts about children, their own or others, that they are not pedophiles and they are not likely to do anything inappropriate. This involves worries. It could involve specific family members or loved ones. It could be about any random child, regardless of whether there's a pre-existing relationship. I've seen teachers who are worried about having sexual thoughts about their students. It can develop after a person has a baby and as a part of postpartum OCD. Or the person may just fear that they'll be accused of sexually harming a child, even though maybe they don't necessarily have intrusive thoughts about that. So it's really important to understand, though, that this is not the same as pedophilia. This is OCD, because these thoughts are what we would call ego dystonic, which means the person doesn't want to have them. And often people will cry or show great distress as they wrestle with these thoughts and try to figure out why they're having them. So actually having thoughts about sexual experiences with a much younger person is very common, even among people who don't have OCD. But most people can dismiss those thoughts, whereas a person with OCD is simply not that easy. I mentioned before that anxiety is very common with OCD. And so, for example, when someone has these pedophilic concerns, what you'll see is that they may begin to have less contact with children, make excuses why they can't wrestle or pick them up or hug them or give them a high five. They may avoid children altogether, making excuses to get out of their own childcare responsibilities if they have children, or see other children, or they won't allow themselves to be alone with a child. They might stop commenting on a child's appearance or refuse to look at a child below the neck to avoid accidentally sexualizing them. They might engage or watch children from a safe distance, what they feel is safe. So maybe could be a few feet away, could be several yards away. And in some cases, they may not be willing to be around children at all. Another type of sexual symptom with OCD could be sexual assault obsessions. And as you know, one of the most upsetting types of obsession concerns worries that a person may cause harm to others impulsively. Common OCD examples include the fear that a person will punch a friend when they're not angry, but just because they can. Or people with aggressive obsessions may be concerned that they might push an elderly person into subway tracks or stab a loved one using a kitchen knife. The focal point of these worries is usually loved ones, but it could be strangers and pets. And sometimes a person's not worried about harming others, but worries about harming his or herself, which is not to be confused with suicidal ideation, as people with these kinds of fears will do anything to avoid causing the harm that they worry about. Therefore, it should be no surprise that these sort of aggressive thoughts can involve sexual behaviors as well. People can have S-OCD focused on fears of seducing other people, sexually harassing them, touching others inappropriately, or even committing a violent rape. I once knew of a patient who would handcuff himself at night to his bed so that he wouldn't get up in the middle of the night and harm someone sexually. That's how afraid he was that he was going to do that. And last but not least, we have impregnating obsessions. And in women, this might look like a fear of getting pregnant when it's very unlikely or impossible that they could be pregnant, such as like from sitting on a toilet seat or being in a swimming pool. They may take repeated pregnancy tests despite no sexual activity, or using multiple methods of contraception beyond what any medical professional feels is necessary. They may eschew sex at all because no method of birth control feels safe enough. And for men, it could be fear of impregnating others through sperm transferred by an unlikely means, such as a handshake, or they touch something, they worry someone else will touch it and may somehow get pregnant from lots of touching. And so this could fall into this category as well. It's really important to understand people with OCD are not dangerous. I think I've made that really clear, but just in case you're still wondering, they are not dangerous, at least not due to the OCD. So I want to clarify, which isn't to say that people with OCD can't ever harm another person, but they are less likely in our opinion, as well as the opinion of any OCD expert you ask, they're less likely to engage in the actions that they fear than the general public. Now, keep in mind, to have this disorder, the thoughts have to be unwanted, and the thoughts are not in line with what a person actually values, nor how they would like to be. But fear and doubt can be so overwhelming that when combined with maybe clinicians who don't have a lot of experience, these can be real concerns. So when someone says they're afraid of being sexually aggressive or inappropriate toward others or molesting a child or being hypersexual, it's hard not to be worried if you're a family member, and even for therapists who don't have experience with these kinds of OCD, it's very normal for them to be concerned too. And so they may seem alarmed, they may collect a lot of extra data, or they may even just tell patients, I'm a mandated reporter, which only makes them more anxious because therapists, we are required to report people if we feel like they may be a danger to vulnerable people. So, so this can be, again, especially bad when working with a therapist that really doesn't have the experience to be properly helping people with problems like this. So what's the solution? The solution, the key to recovery, is a type of treatment for OCD called exposure and ritual prevention. And it is so important to get the right treatment from a provider who knows what they're doing. I do know some providers who are extremely successful using cognitive therapy, but for the most part, the treatment with the best evidence base behind it is exposure and ritual prevention. And I'm not going to go into the details of that therapy because that's a whole nother talk, but I will say that it's got some 4 key components. The first component is psychoeducation, just learning that sexual thoughts, everybody has them. The second step is ritual prevention, and that's when we teach clients how to stop doing their compulsions. Then another part is exposures. These are guided exposure exercises. There's 2 kinds: in vivo, which are real life exercises, and imaginal, which are stories that we might use to help evoke some of the obsessional worries where we practice not avoiding. And the person has to learn to stop avoiding so that they can get better. And so, so these are the keys to treatment. The treatment itself is not complicated. Certainly it does require some nuance and creativity to do it well. So again, having an experienced therapist or a therapist that's being supervised and trained and guided by an experienced therapist is really important. And the treatment, I have to say, it can be difficult. It's challenging for sure, but it's not impossible. It's a short-term treatment. It's an intensive treatment. Not easy, but definitely worth it. Now, for those of you who are clinicians who want to learn more about how to do this treatment, I recently wrote a manual with my esteemed colleague, Dr. Chad Wetterneck, on sexual obsessions and obsessive compulsive disorder. And it's a definitive step-by-step guide for understanding, diagnosing, and treating all kinds of sexual OCD. And I encourage you to make use of this manual to help your clients. But also, I would say it's probably a good idea to get supervision from an experienced OCD therapist if you're new at this. And finally, I just want to say that if you are someone watching this and you have sexual symptoms in OCD, I encourage you to get some help from an experienced clinician. You can always contact our clinic, the Behavioral Wellness Clinic, and we contain the New England OCD Institute, and we have a great team of people who would just love to help you get on your feet and feel better. And we do see people online too. But if you also would like to see someone near you, we're happy to help get you connected to somebody near you, because there are a lot of good places that are doing good work and have a really successful track record of helping people who are suffering get through their OCD. Thank you. Sexual symptoms in OCD are more likely to be misidentified than other symptom dimensions. For example, one study that was done a few years ago, they sent a survey out to clinicians who were members of the American Psychological Association. They sent them at random to members in each state in the U.S. And of these participants, 82% were PhD level psychologists, and the vast majority were licensed professionals. And over half of them reported a cognitive behavioral orientation, which is an orientation that focuses on helping people practically and directly with their issues in a way that is in accordance with science. So each of these psychologists was given a symptom, one of 5 OCD symptom vignettes, which featured one of those types of OCD that I showed you in those bubbles. And each was asked to give a diagnostic impression.